Hello, everyone. It's my pleasure to welcome you all, moderators, speakers, and audience for this webinar, which is consecrated to discussing recent advances in clinical embryology. The Lebanese Fertility Society values the participation of the speakers from Lebanon and the UAE, all with numerous years of experience in this field. I shall make way for our moderator, Dr. Imad Abu Jawdi, to introduce the speakers and start this webinar. Dr. Imad.
Thank you, Walid. Thank you for the introduction. So we'll start the meeting actually with Dr. Mohammed Al-Shmouri on key to embryonic development and beyond. Mohammed is work at Fakih IVF corporate. His laboratory director over 25 years of experience working in IVF. He joined Dr. Fakih Clinic First IVF in 1997 in Beirut. In 1998, moved to IVF Michigan, and in 2010 he moved to Dubai, and currently he is at Fakih NMC Corporate Laboratory in UAE. Currently is PhD candidate at Eastern Virginia Medical School. He holds MS. He has got his degree from American University Beirut and MS degree in clinical embryology and andrology from Eastern Virginia Medical School. He also holds designation of embryology laboratory director and technical supervisor certification from the American Board Bioanalysis in Embryology and Andrology, certified and associate embryologist. From American College of Embryology, co-authored articles that are published in international scientific journal, also authored and co-authored many abstracts and presented as an international scientific meeting and workshop. Mohammed, we are waiting for your presentation.
Okay, thank you, Dr. Abu Jawdi, for the introduction. All right, let me share. Okay. The entire screen. Okay, just wait a minute to share the screen. Okay, hello everybody. Can you see my screen?
Yes.
Hello? Okay.
Yes, yes.
Great.
Yes, Muhammad.
All right. Okay, so the title of my presentation today is the key to embryonic development and beyond. So during this presentation, I'll be talking about defining success in ART and if the number of oocytes does matter. And then I will... Yes?
Slideshow, please.
Okay, sorry. All right. So as I was saying, I will be talking about defining the success in ART and to check if the number of oocytes does matter. And then I will be talking about the impact of laboratory conditions on embryos and ploidy. So first, start with the defining success in ART. So this is the ART milestones over the last 5 decades. And you can see on this figure here, the introductions of different protocols, procedures, even like societies, PGDA, PGDM. So all of these and vitrification of oocytes, all of these was the aim was to maximize the outcome with reducing the risk of the procedure. So first, the success of an ART was traditionally defined as the live birth rate, but now it's increasingly defined in terms of the cumulative live birth rate, defined in terms of the time to live birth and to presence of euploid embryos. And this reflects the efficiency and the safety and cost effectiveness of the procedure. And these outcomes are aligned with the patients, clinicians, clinics, and embryologists. And you know, the success of the IVF procedure, really, it's like it's a multifactorial equation, and there's inputs at each step of the procedure, starting from the patient, from medication, laboratory quality control, and quality assurance, from laboratory personnel, embryologists, and embryo transfer. And really, as an embryologist, I can see that really very small details during this chain of events here, it make a difference and in the success of the procedure. So does the number of the oocytes matter in the success rate? And is there an association between the number of oocytes and IVF outcomes in terms of the embryo quality, embryo aneuploidy, time to live birth, and cumulative live birth rate? So in this retrospective study, we can see that in the first graph to the left here, we can see that the fraction of high quality embryo is increasing with the increasing number of oocytes. And also on the left, on the right side, you can see from this prospective study that there's a negative association between age and number of oocytes retrieved. And also there's a positive increase in, association between the increased number of embryo transferable embryos with the increased number of oocytes. And both that shows that there's positive association between ovarian response and embryo quality. And here from this study, we can see that the aneuploidy is not related to the number of embryos generated. And on the left side of the slide, you can see day 3 embryos biopsied and run CGH. We can see here that there's a negative association and correlation between euploidy rate with the increased age. So as the age increases, the euploidy rate decrease. However, across the same age, that we can see that the euploidy rate increases with the number of embryos generated, increase the euploidy rate. So it's a matter of age that affected the euploidy rate. Same on the right side of the slide, you can see that these are day 5 blastocysts. They have the same trend, that there's a negative effect of age on the euploidy rate, and there's an increase in the number of patients that have at least one euploid embryo increase with the number of embryos generated. So in this case, euploid rate did not vary based on the cohort size, and there's a likelihood of at least one euploid embryo increased significantly by each additional embryo. So there is a relationship between ovarian response and number of oocytes and embryos and embryo aneuploidy. And this slide also shows that with age, the euploidy rate decrease and the aneuploidy rate increase. And on the right side of the slide, you can see here that the number of euploid embryos increases with the number of oocytes retrieved. As the number of oocytes increases, the number of euploid embryo increase at the same time. Now we can come to the question is like, does the dose of the treatment or the gonadotropin dose, has any effect on euploidy rate? And we can see from this figure within the same age group, the euploidy rate, there is no significant difference in 3 different gonadotropin dosage used. But the trend is that there's the euploidy rate decrease with age, but there's no difference in 3 different dosage used of gonadotropin. So, in this case, with achieving high number of euploid embryos, so the next question comes, shall we care of live birth or the cumulative live birth? And this slide, it answers this question, and you can see that with the increasing number of oocytes, the cumulative live birth is really higher than if we consider the live birth rate. So we should measure it as a cumulative live birth rate. And this slide here, you can see from this figure, also shows that as the number of oocytes increases, the live birth rate increases in the fresh cycle. But you can see when we have more than 16 eggs, the number drops, but this is because many patients here got hyperstimulated and there's no embryo transfer. That's why the number are low. But the trend is that with high number of of oocytes, there's increase in, the live birth rate, 40 reached to around 41%. However, if we look into the cumulative live birth rate, we can see that with the increased number of oocytes, there's a trend of increasing the cumulative live birth rate with the increased number of oocytes. So now, here we can see that how many oocytes, the question comes, how many oocytes do we need to maximize the cumulative live birth rate after utilizing of all the fresh and frozen embryos? And in this slide, you can see on the left side, as the number of oocytes increases, the cumulative live birth rate increase. And on the left side, on the right side of this slide, you can see that this retrospective study of around 1,100 women, and you can see that there's increase in the cumulative live birth rate with the increased number of oocytes. And in this really large study, included like 14 centers from Spain and Belgium, and around 14,500 women undergoing first ovarian stimulation for IVF. And you can see here that the cumulative live birth increases with the number of oocytes, and you can see that there's increase in the live birth, but then there's a decrease after like more oocytes are retrieved due to the freeze all and no embryo transfer. So cumulative live birth increases with increasing number of retrieved oocytes. And here we want to see if there's a difference in the different protocols. And you see this graph slide shows here the antagonist protocol and the agonist protocol. And you can see from the results here, there's no difference between the two. And this stratification of number of retrieved oocytes shows an impact on clinical, cumulative live birth in both treatment groups, with the lowest clinical cumulative pregnancy rate in the subgroup 1 to 3 eggs, and with the highest with more than 15 eggs. And the same trend in the both treatment or different both protocols. So now, as we established that the number of oocytes has a correlation with the ART success, let's investigate the approaches that result in higher number of oocytes. So we can see here in this study that the number of follicles is higher when we gonal F recombinant FSH is used compared to high purified HMG or FSH. And in the first to the right here, to the left here, we can see there's 10% difference in number of follicles when we compare gonal F with HMG, and around 16% when you compare gonal F with FSH highly purified. And same trend in the oocyte retrieved, you can see there's 18% difference, and there's 25% difference with FSH with gonal F. And when for the embryos that are generated, you can see also there's a 17% difference when we compare gonal F to the HMG, and gonal F to, there's 43% when we compare gonal F to the FSH highly purified. So gonal F in general produces significantly more follicles, more oocytes, and more embryos when we compare it to FSH and HMG. So in this study that compare embryo quality in recombinant FSH versus HMG, and we can see here that the number of embryos is not significantly different, number of embryos and score, and best number of embryos like toward the end of the table, but all the numbers are like higher toward the recombinant FSH when we compare it to the HMG. And here we want to see if there's like any effect of the using recombinant LH in stimulation with combined with FSH, recombinant FSH compared to the HMG. And you can see here there's a trend in the higher pregnancy rate per embryo transfer for recombinant FSH with LH with the number of oocytes as number of oocytes increase. But there will be highly significant difference when we have more than 8 oocytes. And then also the same trend for mature oocytes, metaphase 2 oocytes, there's increase in the recombinant FSH plus recombinant LH, and this difference will be highly significant when we have more than 8 oocytes, mature oocytes. Okay, and want now to see if there's a the type of the gonadotropin used on the embryo quality. And in this here study, we can see that when recombinant FSH used, the embryos consume more oxygen than embryos that are produced with a different gonadotropin. And on the right side here, you can see that embryos that consume more oxygen, they tend to implant compared to the embryos that didn't implant, which didn't consume much oxygen. So the embryos that have higher oxygen consumption, they tend up to have higher implantation rate. And in this study, it showed that recombinant for the recombinant follicular stimulating hormone plus recombinant LH when compared to HMG. And we can see here that for pericovirus, we have the numbers are higher for number of oocytes, number of mature oocytes, and a number of fertilized oocytes. So when we compare it to menopause. And this study here, it shows that the gonadotropin has an effect on the morphokinetics of the embryos. And this study here showed that recombinant FSH with LH, there are higher embryo quality in terms of morphokinetics when we compare it to the embryos generated using HMG or highly purified HMG. So recombinant FSH with LH will produce more embryos, good quality embryos in terms of morphokinetics that tend up to have higher implantation rate using time-lapse technology. So now I'm going to switch the gears and talking about the impact of laboratory conditions on embryos, embryo aneuploidy. So as we see now, all that the number of eggs is important, or site important, that will generate more embryos. And if we have more embryos, we will have higher chance of getting more euploid embryos. But we need to keep these embryos and these oocytes in the laboratory in good culture condition to have good success. And from that, we want to have culture environment that is similar, close to the natural environment, to keep these embryos happy and not stressless in order to maintain their viability. And for that, we need a good culture system. And if we have good quality control and good quality assurance program, this will guarantee us that we have good, stable culture environment. And I'm talking about the culture system, including culture medium, about the air quality in the laboratory, about the environment of the incubators, about the heating stage temperatures, about the plasticwares in general, about the oil we are using. All of these affect the culture system and affect the outcome. So it's very important to maintain the temperature of the heating stage, or to keep the embryos at 37 degrees from the time the eggs are retrieved to the time at the freezing or embryo transfer, it's very important to keep the embryos at 37 degrees during all steps in the laboratories, all the procedures. And there's many studies in literature that show that exposing embryos to fluctuation in temperatures could lead to adverse embryo development, and even could lead to increasing rate of aneuploidy. Same thing for pH. We have to maintain the pH at a physiological range that keep the embryos happy in the culture condition. So we have to maintain this pH, and the pH is, it's affected by the CO2, by bicarbonate in the medium, by temperature and the lab altitude. And it's very important to maintain the pH at the physiological range, in the physiological range. Also, the laboratory environment is very important, and we should have like a room that is really free from volatile compounds, from particles, and controlled in temperature and pressure. And this has all to do with the air handling unit. So we should have very good air handling unit in the laboratory that have HEPA filters, carbon filters, and biomanganate filters that remove or prevent VOC from entering into the lab. And there's also many studies that shows really VOC are very toxic to the embryos, and they stress the embryos and lead to embryo arrest or aneuploidy. And this is very important study, interesting, that it shows chromosomal abnormalities are linked to culture conditions such as temperature, pH, as well as hormonal stimulation. And this shows that for donor oocytes, there's are different results, different outcome from different laboratories. And this is due to the variation from lab to lab in the culture conditions. And here this also, it's a recent study that shows 4 genetic laboratories also using donor oocytes that report different results. Like for laboratory A, aneuploidy rate is 73, laboratory B is 63, C 60, and D 52. So it's the same genetic testing, like 24 chromosomes, but they reported different results in the donor oocytes. And even the mosaic rate is reported differently, with the highest rate in the lab A, which is around 10%, and lowest in lab B, 2%. And even there's a difference in the live birth rate between these 2 laboratories in the laboratories. And the conclusion is that some pre-implantation genetic testing for aneuploidy laboratories report a significantly higher euploid blastocystis rate with concurrent higher live birth rate. So, but recommended that further research is needed to evaluate the differences in the laboratory techniques and bioinformatics algorithms accounting for variable outcomes in the PGTA laboratories. So in conclusion, cumulative live birth rate is an ideal outcome measures of ART effectiveness with consideration of all outcomes according to the patient-related characteristics. Ovarian stimulation has a vital role in maximizing the success in ART and reduces time to live birth. And the number of oocytes retrieved is an important prognostic variable in IVF. Transferable good quality embryos positively correlated to oocyte numbers. More euploid embryos with more oocytes and not affected by gonadotropin dose. Positive association between oocyte numbers, transferable embryos, euploid embryos, and cumulative live birth rate. Recombinant FSH can maximize the outcomes by producing more eggs, high quality embryos, and increasing chances of higher cumulative live birth rate. And there is a strong association between center-specific ART treatments practices and the incidence of chromosomal abnormalities in human embryos. Thank you for your attention.
Maybe we'll have time for some question, or wait. Maybe we'll see what you have as question. There is a question, Muhammad, what is the minimum oocyte we need to have an haploid embryo?
Let's see here if we can go to this study here. Just 1 second, and just go back here. Here, if we can see here that the number of embryos generated here per woman. So when we have like 8 to 10 embryos, for example, regarding the, it's important with the age. So whenever we have like a young patient, the more we have, the higher the chances, the more we have embryo generated, the higher the chances to have at least one euploid embryo. But the best number is to have higher euploid embryos is like around like 15 oocytes.
Okay. What is the mean? What mean by cumulative life birth rate?
Cumulative birth rate, for example, for example, you do like more than one embryo transfer, but from the same cohort of the embryos. For example, if you have like fresh embryo transfer, but you froze the rest of the embryos, but the patient didn't get pregnant, then she goes through another FET or another third transfer. So it's the pregnancy from the same cohort of the of embryos, same cycle.
Okay. So we can move to Dr. Samir.
Yes, hi, Dr. Ahmed.
Samir is a clinical embryologist with more than 24 years of experience as IVF laboratory director. He has worked in prestigious hospital within UAE. Before joining University Hospital Sharjah as IVF laboratory director, he has special interest on quality and continuous improvement of IVF lab protocols and equipment, CME, educational session. Muhammad, the floor is yours. So,
Samir.
Samir, sorry, Samir. 30 years of ICSI and IVF. But you look young for 30 years.
Yeah, I've been working around 27 years, but I will talk about 30 years of ICSI, of course, because actually we've passed. It's already 31 years or 32 years of ICSI. Before, I would like to thank you, Dr. Ahmed, thank the Lebanese Fertility Society for hosting me, and thank Dr. Walid Al-Ghutmi. And as we started the discussion, I will be talking about one technique that we have been using for approximately 30 years, or a little bit more now, 31 years. And actually, there was a dedicated session in the last ISHRE meeting in Milan last year about this topic, and they celebrated the occasion with a special session, and they talked about the technique there. And I have started my my ICSI journey in 1995, Dr. Ahmed. It was in the Fachhochschule in University of Lübeck, and if I take you back historically about the start of IVF, and in the exactly 1978, when this lady, everybody knows, Louise Brown, was born, the technique that was used at the time, it was IVF, or what we call conventional IVF. And I'll explain a little bit about it for those participants who are new to the field or they don't know much about it, where the sperms and the eggs, they were just simply mixed together in a test tube. And I will show a small video, which I took from my laboratory. As we still do IVF procedure, when the semen parameters are normal, we don't go for ICSI, we do IVF. And we can see here in the culture dish, 1, 2, 3 oocytes. And with the use of a micropipette, we just add few microliters of the prepared semen sample, and we can see the shiny, glittery sperms swimming around the oocytes at the this part of the screen, and the oocytes. The cumulus complex cells is this big thing here, and the egg is the white thing, and then all these sperms will start to swim and to penetrate the cumulus complex and then reach to the egg and do the fertilization. Problem with the technique, it was successful with some patients, but as we know, it's not always the case, because we have also male infertility, and there was around 40% fertilization failure in this technique due to abnormal semen parameters in concentration, motility, or morphology. So scientists, they started to look for a better outcome of the process, and on their way to do this, they tried to develop some techniques, including the zona thinning, as we can see here, just to make the just thinning of the zona to make the penetration of the egg easier, or what we call here zona drilling. That one, first one was thinning, and this is drilling. We have here the partial zona dissection and the subzonal sperm insertion. As we can see here, few sperms were put in the space between the egg or the oocyte and the zona pellucida. And finally, they did the XC intracytoplasmic sperm injection, which is the XC technique, as we all know. In the XC technique, I'll just show a little demonstration. As one sperm is selected, and it's taken inside a very fine micropipette made of glass, and then the egg is stabilized with a holding micropipette, and then it's injected inside the oocyte. I'll show a small video again, just for a demonstration for our participants here about the XC technique. As I said, this is the oocyte, and this is the stabilized with a holding micropipette, and then we have here the micro injection pipette with a sperm inside of it, and then the sperm is brought to the tip, injected inside the oocyte. We aspirate to break the membrane, and then inject back again. And the sperm is left inside the cytoplasm and kept in culture for fertilization check next day. So as I said, and looking for a better way to enhance fertilization rates, especially for male factor cases, the XC technique was developed, and there was some reports coming from Singapore. This was in 1991 about injection of use of the XC technique on human oocytes, and it had a better fertilization rate and a better outcome. So this technique was adopted by the the Free University of Brussels. And at that time, they used to do mainly subzonal insemination of the sperms, or what we call the SUSI. And they had one case of a woman which was aged 38 years, and she had 14 eggs collected, 12 of which were M2. And they did 11 subzonal inseminations, 11 oocytes with subzonal insemination, and one egg was injected with a sperm by the XC technique. And none of the subzonal sperm insertions fertilized, while the XC case fertilized and developed an embryo, this embryo was replaced and a pregnancy test was positive. And later on January 14th, 1992, around 31 years back, a baby boy was delivered as a result of the technique. And of course, this was published, and the technique was very fast, common, and as we can see here through the years, the percentage of IVF-ICSI, the ratio of IVF-ICSI cycles through the years has changed from, let's say, around 1995, 20% of the cycles were ICSI, and here in the dark blue, and around 80% or less were IVF. Some gift cases were here. We did the gift using the gift up to the early 20th, and in the year 2000, 2002. I remember we used to do this the beginning in Dubai, but we've completely stopped. And through the years from 1995 up to now, the percentage of cycles has reached up to 70% ICSI compared to the IVF. And this is from the ECMART data. And the same with the same reporting compared to the region, we can see on average of 70% of the cycles are done with ICSI, but in some areas, like in Africa here, we have around 90% of the cases are done by ICSI. Again, here the same. This is the distribution of ICSI and IVF through the world, and we can, as I said, in some countries it has reached more than 90%, as we see here in dark blue areas. Some studies have been done to compare the outcome of ICSI and IVF, and does it really improve the outcome of ART cycles in non-male factor infertility compared to the conventional IVF? Does it have any benefits? And this study was in the Human Reproduction Journal in July 2022. And in summary, there was no statistical difference in clinical pregnancy rate, implantation rate, and live birth rate found between ICSI and IVF in both age group. This is for the non-male factor infertility cases. The study was for the non-male factor infertility cases. And of course, for the male fertility or other indications, there is a much better outcome. And here I will share with you some of the data and the outcome of ICSI for these male factor cases. And ICSI, of course, some of the indications that is used ICSI, I will talk about the indications, first, before I talk about the outcome. And as we can see here, it can be used for male factor. And when we talk about the male factor for the ejaculated sperm, with all the abnormalities of the semen parameters from oligospermia with a low count, astenospermia, low motility, terato, low morphology, anti-sperm antibodies, fertility preservation, ejaculated disorders, and so on. In cases of epididymal sperm, use of epididymal sperm, this is a male factor again for the obstructive azoospermia, congenital by absence of the vas deferens, Young syndromes, failed vasectomy, vasovasectomy, and cases of testicular necroazoospermia, all indications of epididymal sperm, non-obstructive azoospermia, and hypospermatogenesis. What about non-male factor indications for the XC, it can be used in cases of prior fertilization with IVF, in cases of oocyte dysmorphism, low number of oocytes, low oocyte maturity, preobserved oocytes, in vitro maturation, PGTA, PGTM, as we can have some possible of contamination of the sperms attached to the zona or the granulosa cells remaining on the zona pellucida. Cases of HIV, hepatitis C, discordant couples. Now I want to share with you the outcome of semen origin and ICSI outcome, as I said, and this data was presented by Palermo from et al. From Belgium, and they had around 38,000 cycles, and the use of ejaculated sperm, electroejaculate and retro-ejaculate, and there was a fertilization rate of 75% on average for all the semen sources, and with a clinical pregnancy of 37, 46, and 36. This is from 1095, 93 to 2022 for the whole time. And as in cases of severe oligospermia, what is the outcome of ICSI in cases of severe oligospermia? When we talk about less than 1 million count, they did around 2,400 cycles with a mean density of 0.9 million sperm per ml and a motility of 19%. And the fertilization rate with these cycles was 61, around 62%, with a clinical pregnancy rate of 46%. As for the cryptospermia, when the initial count is 0, but when we do ultracentrifugation, we can find few sperms, and they did 377 cycles, and with a concentration of 0.34 million sperm per ml, and the motility of around 32%, with a fertilization rate of 53, and clinical pregnancy rate of around 43%. In cases of azoospermia, when there is no sperm in the ejaculate, they did around 3,400 cycles. Epididymal and testicular sperm. And in the cases of obstructive azoospermia, in cases of its congenital and acquired, there was a fertilization rate with 72% and 69% respectively in the fertilization rates of the microsurgical retrieved sperms, and a clinical pregnancy of 52 and 42%. In cases of testicular sperm aspirations, there was also divided into two groups, obstructive and non-obstructive. And in the obstructive group, we had 66% fertilization, and the non-obstructive 48% fertilization, with a clinical pregnancy of 42 and 35%. Now, for the outcome of the ICSI cycles in the ejaculated and the fresh and the frozen, between the fresh and the frozen, in the ejaculated sperm, we had a comparable fertilization rate of 75%. In the microsurgical sperm aspiration, 71, and in the testicular sperm aspiration, 49% fertilization rates. That's in summary. And between the fresh and the frozen testicular sperm, epididymal and testicular sperm, we had 60% in the fresh, 44% fertilization rate in the testicular sperm, and with the frozen, it's a little bit lower, between 46 and 40%. As for the ejaculated, and this is a comparison between the ejaculated between motile and immotile, use of motile sperm. In the ejaculated sperm, the fertilization rate between, there is a huge difference, as we can see, between the motile and the immotile sperms, the use of motile and immotile sperm, and the clinical pregnancy and the delivery. And so the outcome is hugely affected when we are using immotile sperms. I mean, those cases where motile sperm was not possible to found. And in the testicular group, again, the same outcome with a huge difference in the between the motile and the immotile sperms. So it's always better to look for the motile sperm, and that's what we always do in the lab. And we try to use the theophylline or pentoxifylline to check for the motility, or sometimes we have to go for the host test. As for the sperm DNA fragmentation, sperm DNA fragmentation, there's a big link between the paternal age and sperm DNA fragmentation. As we can see here, with advanced maternal age, the more we get DNA fragmented in the semen samples, and also we can see this in the abstinence, days of abstinence. And this is maybe an important part which many centers are missing. As we can see here, with the least sperm DNA fragmentation of 28% in the 0 to 3 days of abstinence, and more than 5 days, we have up around 50% of the sperms, they have fragmented DNA. So how to overcome this? Now we all know about this new techniques for the sperm separation, and we have the what we call the microfluidic chamber. And as we can see here, the sperm chromatin fragmentation, if we did analysis of the sperms after the use of the techniques, like here for the density gradient, it's around 18%, while when we use the microfluidics, it drops to 1.5%. So I think these chambers are very promising in semen preparation and reducing the fragmented chromatin. And also the use of these sperms in with the XC reduces the aneuploidy rates. As we can see here, when we're using the density gradient, we have around 72% aneuploid of the embryos, while when we are using the microfluidics, it increases the haploid to around 50%, and the aneuploid is here, as we can see here, 51%. And of course, we all know this slide about the maternal age and the pregnancy, and with the highest pregnancy rate in the group, the young group, and going to the going down with the maternal age increasing up to like 46%, 46 years. And one of the last things that I would like to talk about is about now the advancement of artificial intelligence, and microfluidics has developed a new techniques of the ICSI, and now there has been some reports about ICSI doing ICSI on a chip, and we all know that for the ICSI technique we need an expensive micromanipulator and the inverted microscope with the heavy apparatus, and things are changing, and the future is bringing in new techniques. And this was presented last Ishre in Palermo by Professor Palermo about introduction of ICSI on a microchip, and I will show a demo of the technique. And as we can see here, it's a device with the size of our iPhones. And this device is inserted into a special a machine, and then we put the eggs here on one chamber. We'll put the oocyte cumulus complex on this chamber, and then on this side we can deposit the sperm samples, and then with the help of microfluidics and electromagnetic valves, we allow the passage of one oocyte, and then the hyalase or the hyaluronidase enzyme is injected here in blue, as we can see. And again, with the help of microfluidics, it will remove all the cumulus cells around the egg. And the egg is pushed to a face recognition system where the maturity can be assessed, as M1 or GV oocytes will be pushed on the side. While mature oocytes are taken to the other part of the device, and again, microfluidics will help to take one sperm, which is inactivated by a laser beam, and then the electromagnetic valve take it inside a piezo drill. So the oocyte is injected with the help of a piezo drill, and then cultured into something similar to the embryoscope or the time-lapse system. So this is where the future is taking us. And in conclusion and in summary, I would like to say that ICSI is an effective method for treating male factor infertility. ICSI is a reliable and consistent technique. ICSI is overused in non-male factor cases. Automation and AI is the next chapter of ART. Thank you so much.
Thank you, Samer, for this very nice talk. It's not 30 years, it's 30 years before and after.
Yes.
So past and the future. We have some question in the chat. So IVF, is it better to do denudation or not?
Is it better to do
Or
denudation?
IVF, is better to do denudation or not for IVF?
We don't do denudation with IVF. We have to inseminate with the cumulus cells around the oocyte, and we let the sperms do their job in penetrating and dissolving this cumulus complex.
What is ideal semen count per oocyte for IVF?
We culture in a 4-well dish. We use 600 microliters of culture media. And in each dish, we put up to 4 oocytes. And then we do the calculation. So we will have a concentration of 100,000 sperm in the dish. So that's like 25,000 sperm per egg. And in some cases, when we have lower progressive motility, or we have reduced fertilization rates in the previous attempts, we increase this to 200,000 sperm per ml.
There is a question that I don't understand very well. I would like to know when there is an A2 breakage, but the fertilization is less, what will be the tip and tricks for a high fertilization rate? And does the double aspiration help in improving the fertilization and embryo development? I don't know if you understand the question.
I would like to know when there is a A2 breakage,
but the fertilization
is less, but what will be the trip or trick for a high fertilization? And does the, I know I don't understand the question, but you have to make sure that the sperm is of good quality and the semen parameters are of normal readings, and the swim up or the outcome of this semen preparation is also in good count and good progressive motility. That's very important, and the insemination volumes, and that's it.
Okay, so which media can be used to improve blastocyst rate instead of PVP in our ICSI dish?
I don't know. We are using the PVP all the time. Yes, there are different types of PVP and different concentrations, 7%, 10%, or maybe there are some other synthetic PVPs. I'm not sure about it. Yeah, but I don't know if it's really related to the some centers. I know sometimes like Bornholm, for example, in UK, they don't use PVP. I don't know how they do the ICSI. They do it without PVP. It's really very difficult, but I've seen this. They don't use PVP and they consider like it's toxic, it's synthetic. We should not introduce inside the egg. But honestly, doing ICSI without PVP is very difficult. I tried it. You can ruin the egg easily. You can aspirate all of the cytoplasm in a millisecond. So maybe the benefits or the disadvantages outgrow the benefits.
Can we get embryos through IVF in case of retrograde ejaculated sample?
If the semen parameters are normal, yes, we can.
Yes. Based on our valuable experience, does IMSI improve outcome of ICSI failure? What are today indication for IMSI?
I don't know much about IMSI. I know that it has improved the fertilization rates, but the outcome or the pregnancy rates are not improved. And
I think IMSI is for the past. Yes, I agree. Is SDF higher with swim up technique in compare with density?
Yes, as I showed in the slide, it was much 22% in the compared to 18% in the density gradient, and 1.5 it was in the microfluidics. And I think Muhammad has one time or several times he showed they have a good outcome with the microfluidics using chambers.
Mm-hmm. Is IVF an optimal technique for low quality oocyte?
Yeah, this is sometimes we have to take decisions in the lab whether to use our IVF or not. The thing is that the semen parameters that must be normal. Once we have a normal semen parameters, then the choice is IVF. But as you can see, like maybe egg quality is not that good. You're not happy about the shape, the morphology of the cumulus complex cells. And worst part, you can just make a ICSI sample, just clean the eggs, see what's inside there, mature, immature, what is the quality, and do ICSI. I mean, but you have to take a decision on the spot, what to do, ICSI or IVF. And if you think that ICSI can be in favor of the case, just do it. I mean, it's at the end, you're not harming the patient or the oocyte. You're trying to give them what is best for them.
Okay, so I think the other question you can answer after not live. You will maybe answer them directly. It's maybe it's better. Okay, we'll move to the next speaker now to Dr. George Raad. He will talk about a very interesting topic. Lactobacillus plantarium secretion may exert a cryoprotective effect on human spermatozoa, a prospective in vitro study. Very interesting. George was my student in Lebanese University, We know him very well. So George is a lecturer, researcher, and senior embryologist and scientific director at Al Hadi Hospital and Medical Center in Beirut. He is also a lecturer at USAC Faculty of Medicine and lecturer at Lebanese University Faculty of Science. He has publication in embryology, reproduction, and infertility. George, the floor is yours.
Good evening, Dr. Ahmad. Good evening to everyone. So I am very happy to be with you today to discuss with you the results of our project entitled Lactobacillus plantarum secretions may exert a cryoprotective effect on human spermatozoa, a prospective in vitro study. So this research was accepted in Embryology and will be published very soon, but we have no conflict of interest to declare. Let's start with a brief introduction about this topic. So Lactobacillus plantarum secretions may protect host cells. How? L. plantarum is a gram-positive bacterium. It has many properties, such as antioxidant properties via secretion of antioxidants such as carotenoids. It has an antimicrobial property by secretion of lactic acid, and it can have anti-inflammatory property by inhibiting cytokines production. Due to all these properties, preclinical studies on mice tried to decipher the effect of Lactobacillus plantarum on semen. To this purpose, scientists exposed male mice to toxic molecules and to high-fat diet. These exposures may increase inflammation and can induce oxidative stress, thus leading to alterations in sperm quality. In parallel, oral administration of Lactobacillus plantarum to these mice exposed to toxic molecules and to obesity alleviated inflammation and oxidative stress and improved fertility. In the same line, meta-analysis on clinical studies tried to study the effect of Lactobacillus plantarum on human semen. A meta-analysis published in Embryology showed that semen of fertile and infertile men is rich in bacteria. Particularly, microbiome of semen of fertile man is predominantly occupied by lactobacilli. However, semen of infertile man may contain certain bacterial species that can cause sperm damage. In parallel, sperm damage can be induced by freezing, because during freezing, due to osmotic shock, ice crystal formations, etc., DNA fragmentation may occur, and sperm DNA fragmentation can lead to alterations in embryo development. Moreover, mitochondrial damage may occur, leading to oxidative stress. Additionally, sperm morphology may be altered, such as tail damage, leading to motility loss. These alterations are more pronounced when the semen is coming from non-normospermic sample. Also, these lesions may happen independently of the brand of the cryopreservation media used. However, the interaction between Lactobacillus plantarum secretions and the semen during cryopreservation has never been investigated. Therefore, our research objective is to determine whether the addition of Lactobacillus plantarum secretions to sperm freezing medium has an impact on sperm motility, morphology, and sperm DNA fragmentation. How did we proceed? First step was to supplement sperm freezing medium with L. plantarum secretions. We used a culture dish containing several wells. Each well is made up of 2 compartments that can be separated into upper and lower compartment. The upper and lower compartment can communicate together via small pores on the base of the upper compartment. Next, the upper compartment was filled with antibiotic-free sperm medium, and the lower compartment was filled with antibiotic-free sperm freezing medium. Then the first well was kept as control, the media without any bacteria. The upper compartment of the second well was filled with a 10⁻⁷ colony-forming unit Lactobacillus plantarum. And the third well, in the upper compartment, we have added 10⁸ colony-forming unit per ml of Lactobacillus plantarum. Then this dish with all the bacteria and the different concentration was incubated in an incubator at 37 degrees Celsius under 5% CO2 for 30 minutes. Why only 30 minutes? Because more than 30 minutes, Lactobacillus plantarum start to produce lactic acid that can acidify the medium and cause sperm damage. After the 30 minutes, we have removed the upper compartment and we have collected the sperm freezing medium in 3 different tubes. The first tube containing sperm freezing medium without any secretions of L. plantarum. The second tube contains sperm freezing medium with secretions coming from 10 power 7 colony forming unit of L. plantarum. And the third tube containing sperm freezing medium with secretions coming from 10 power 8 colony forming unit L. plantarum. Now let's move to the next step to freeze the sperm. We have invited infertile man attending Al Hadi IVF Center for semen analysis. We have only included fresh ejaculated semen samples with a minimum volume of 1 ml at a minimum concentration of 5 millions per ml. We have recruited 30 infertile men. Each sample was divided into 3 aliquots, and each aliquot was frozen with 1 sperm medium without L. plantarum or with sperm freezing medium containing secretion from 10 power 7 or 10 power 8 colony forming unit L. plantarum. Before any freezing, we have assessed on raw semen the motility and morphology according to the World Health Organization. Then we have assessed DNA fragmentation using sperm chromatin dispersion test. Then, after thawing, we have assessed again sperm motility, morphology, and DNA fragmentation in the different freezing conditions. What did we obtain? Here in the x-axis, I am showing you the percentage of the progressive motility, and in the y-axis, you can see the different freezing conditions. Interestingly, there was a significant decrease in progressive motility in the control, which means sperm freezing medium without any secretions of bacteria compared to raw semen. However, no significant decrease in progressive motility was detected in sperm freezing medium containing Lactobacillus plantarum secretions, thus indicating a chiroprotective effect of L. plantarum secretions on progressive motility after thawing. The second parameter, as you can see in the x-axis, was the non-progressive motility percentage. And in the y-axis, you are seeing the different freezing conditions. We had a significant decrease in non-progressive motility in the sperm freezing medium without L. plantarum and in the sperm freezing medium containing 10 power 7 colony forming unit per ml L. plantarum secretions compared to raw semen. However, there was no significant decrease in non-progressive motility in the condition where we had secretions coming from 10 power 8 colony forming unit per ml L. plantarum secretion, thus indicating a chiroprotective effect of L. plantarum secretions on non-progressive motility after thawing. The third parameter we have assessed is the DNA fragmentation. Badly, in all the freezing conditions, the sperm DNA fragmentation increased compared to raw semen. In order to understand more what happened, we did a subgroup analysis. We have divided the samples into 2 groups, the normosospermia participants and non-normosospermia participants. Non-normosospermia was defined by the presence of at least 1 abnormality in the semen sample. Interestingly, no significant difference was found in the DNA fragmentation in normosospermic participants after thawing compared to raw semen. However, in the non-normosospermia group, we had a significant increase in sperm DNA fragmentation only in the control group, which is a sperm freezing medium without L. plantarum secretion compared to raw semen. Let's discuss these findings. First of all, our results are in line with several papers showing that frozen semen sample from non-normospermic man should be used only when necessary. Why? Because several meta-analyses, as you can see in the references down at the bottom of the slide, several meta-analyses showed that spermatozoa from infertile man had a more chance to have a non-condensed chromatin, which is more prone for DNA fragmentation. The semen of infertile man has a low antioxidant capacity, and recently, the semen of infertile man has a specific seminal microbiome signature, which may induce sperm damage. And in addition, if we freeze the sperm in liquid nitrogen, it will enhance the damage. Moreover, this is the first study showing that freezing medium containing L-plantarum secretion was able to protect sperm, particularly in non-normospermic men. It is very important in IVF to use sperm, healthy sperm, intact sperm, because using damaged sperm for ICSI or IVF may increase the mutation loss in progeny. And after this validation and in vitro study, it is now very important to conduct clinical trials to assess the effectiveness of modulating seminal microbiome in vivo on sperm biology. This work was not possible without the help of the amazing research team. Let's start with Dr. Shadi, Yumna, and Fadi, the owners and medical directors of Al-Hadi, my amazing embryologist, Marwa, Vinal, and Estelita, and a big thanks for the collaborators from Cyprus, Zalihe and Ninufer. Thank you, Lebanese Fertility Society, and thank you for the audience.
Thank you, George, for this very interesting topic, which focused essentially on the importance of lactobacillus, which was not clear in the literature. We know that lactobacillus is present in the sperm and the ejaculate, but we don't know exactly what will improve it and what will not improve it. So you put your point on a very important future subject, which is not very clear today. So we'll see what we have as question. Thank you. This may have benefit on other parameters other than do this secretion may have benefit on other parameters other than motility and DNA fragmentation.
It will be very interesting to assess, for instance, acrosomal reaction, mitochondrial activity. We'll conduct this study further later on.
Okay, yes, very important. Can we inject spermatozoa embedded with lactobacillus plantarium and ICSI procedure independently of ethical problem?
We have to take an ethical approval and to register this trial in clinicaltrial.gov, and then we can conduct this trial. Why not?
Okay. Is Max technique is helpful? I think it's not our subject here. So I think these are the questions for you. So I think we finish because Dr. Brahim will not join us. He's sick. So we have to conclude here. Thank you, everyone. Thank you for all the speakers. And
Thank you, Dr. Ahmed.
It was a very successful and interesting topic. I have a question for Dr. Samer. Maybe what is the maybe Dr. Muhammad, the problem of aneuploidy during ICSI? How do you explain it exactly? Because there is, as you show it in the studies, some centers have a higher aneuploidy rate depending on the centers. Do you think that there is a technical problem, and how we explain this technical problem?
You're mute, Muhammad.
I can't hear you.
Okay. All right. I don't think the ICSI technique itself will lead to aneuploidy, but it could be the environment that you are when you are doing the ICSI, or the like exposing the eggs or the sperm to an unfavorable environment during the procedure. This could lead to aneuploidy. Like if you expose them to a long time outside, with pH will change, or you expose them to a temperature change at time of the procedure, then this could lead to increase the rate of aneuploidy. But the ICSI technique itself, I don't think it will lead to increase the aneuploidy rate.
Maybe I didn't formulate well my question. It's on PGD. When they do the different aneuploidy rates from different centers, they found different result in the same genetic lab. So they thought that during PGD there is a problem, something creating aneuploidy. What do you think
Yeah,
about?
well, I mean, in the genetic study, when they have 4 different laboratories, so there's different techniques and the procedures, different platform, what they are using, which algorithm they are using, what machines are using. All these different machines, different protocol, different algorithm could lead to different results.
Mhm. Okay, Dr. Walid, do you have any comment or do you want to conclude?
No, I thank you very much. Thank you, Muhammad.
And by the way, one more
Sam.
thing, just Dr. Wayne, the way they are reporting the results could lead to this difference also. Some labs, they might see the small noise like in the reading, they just consider it as abnormal, or some labs, they when this small noise, they just consider as normal. So also the way they reporting the results make a difference in the unemployed rate.
Yeah, but I think in this issue, you have so many variables to consider, because the study that you have shown suggesting that you have different unemployed rates in different laboratories, you have so many variables to consider, and I don't think you can rely on this study alone. And if you consider other studies or even observational things, like in the same lab, you may find some patients having reported a lot of aneuploidies, another patient having 100% of her embryos reported as euploid, and both are done by the same embryologist. I think we need more studies to confirm whether it is due to lab variabilities or to other causes. I don't
Yeah,
know.
that's true, but we should consider that they used donor oocytes. All they use donor oocytes, but there's definitely a variable different variables in different laboratories. So definitely need more controlled studies to prove it.
Well, thank you very much. Thank you, Dr. Ahmad. Thank you, Dr. Shmouri. Thank you, Dr. Samer and Dr. George, for the excellent
Thank you, Dr.
presentations.
Thank you so much.
Thank you.
for the invitation.
I hope we'll meet again in another meeting.
Okay, thank you. Bye.
Thank you.